Well, I was born in El Paso, Texas. My dad was a career Army guy, just kind of a grunt guy from the sticks in Alabama, and joined the Army when he was 18 to get out and be able to do something, and was stationed out at Fort Bliss when I was born. Met my mother out there, and I lived there until I was 11 years old, and he was retiring after 21 years and looking, for something else to do, and wanted to get back close to his family in Alabama, but not right on top of them. So moved us to Jackson, Mississippi, and got a job teaching ROTC in the Jackson Public Schools in '79. So I moved here in sixth grade, and grew up the rest of the time in Pearl, Mississippi. Graduated from Pearl High School in '85. Went to Millsaps, which is a little small liberal arts school in Jackson. And majored in math, and ended up getting a job as a actuary at Southern Farm Bureau Life.
And it's a private school, right? Millsaps?
It is.
Yeah. So did you take out student loans, or not to get your finances, but
no. So
no scholarships or anything?
Well, I had a National Merit Scholarship, and it covered a good bit, but I still had it's a pretty expensive school. It's like the most expensive school in Mississippi, I think, and it has a real good reputation. But so finished there, and got a job as an actuary. Got married pretty much right out of college, and
did you guys meet there? Did you meet at
No, I had met her actually when I moved to Mississippi shortly afterward, and she went to the church that we went to. So I really had kind of known her, since I was in about sixth, seventh grade. And then we started dating like her senior year of high school.
Okay.
And got married actually during my senior year of college when I was about 6 months away from graduating. So a couple of years later, I guess so, we got married at the last day of '88. We got married New Year's Eve. People always say, well, what, were you just drunk? No, we kind of planned it. And so Morgan came along, the oldest, in '91. Okay. And Macy was born in '92. We're the first two. And so just sailing along, kind of, fairly happy with, my career. And, I'm really not kind of a rules following kind of guy. And so I liked the work I was doing, but, I didn't really like the whole corporate life. And, people telling me, what time I had to be there and what time I had to leave. I was just like, as long as I'm getting my work done, what difference does it make? And, had to wear a tie every day and just bristled at that. So just never really liked the regimented corporate stuff, though I did like the work. So in '97, Manning was born. And so the older girls, were already 5 and 6 years old. And, he was a parent right away within, he'd started season within about 2 weeks after birth, and just never could get him stopped. He got started on phenobarbital, did great for a week, started season again. And at that point, he's really too little to know how delayed he was going to be. I mean, he was just an infant, not doing anything anyway. But, by 3 months, he was not able to do anything, not holding his head up, not doing anything, and was still having seizures. And, it became apparent pretty quick that he was, not meeting milestones and really not doing much of anything. So, by 6 months, we had him in first steps early intervention and was getting therapies, and we're continuing to try to treat seizures. He got diagnosed with a particular bad type of seizure in infancy called infantile spasms that kind of go along with several bad epileptic encephalopathies. And we had to do ACTH injections on him. We tried, virtually every medicine out there. We got him on something called the ketogenic diet, where we were, doing this high fat diet. And essentially at the time, now they have a ketogenic formula, but at the time we were literally like creating this formula with Wesson oil. And, Angie would just get a bottle of Wesson oil every 2 days and pour it in a pitcher along with this powdered protein, where you need to get just enough protein to keep you from breaking down your own muscle, and then a tiny bit of glucose. And so it's a very regimented formula where like 80% of his calories were coming from fat. And he had a G tube by then. So this would have really been when he was getting somewhere between 18 months and 2 years, because we had the G tube put in shortly after a year old, just because it just took him forever to eat. Taking a bottle, it would take hours to get enough calories in him. So we got the G tube put in so we could get him, get calories in him, and so we could give him this horrendous formula through the G tube. And
you guys, neither one of you had medical experience, right?
No, we didn't know what the hell we were doing, or what was going on or anything. So, it was all completely, foreign to us. We were going to a doctor in Huntsville. We had tried to get him started. There was a new drug out for infantile spasms called vigabatrin, but it didn't have FDA approval. It was in trial stages. And we found a doctor who was involved in the clinical trials in Huntsville, Alabama, a pediatric neurologist, Martina Bevan, who's still up there. And she's kind of the queen of tuberous sclerosis. And tuberous sclerosis babies frequently have infantile spasms. Tuberous sclerosis is another genetic condition. So she agreed to help us with doing the vigabatrin, except he didn't qualify for the study because he had already had ACTH, which is a synthetic hormone type drug. And the study was for only babies naive to ACTH. So she couldn't enroll him in the trial, which means she couldn't get the drug for us. But she said if we could obtain the drug, that she would monitor him. So my mom, who's fluent in Spanish and grew up on the border in El Paso, started going across into Juarez, and you could just go to a pharmacy there and just ask for it. It's like no big deal. It was not a controlled substance or anything. It just wasn't available in the US because it didn't have FDA approval. So, but she did have to smuggle it across the border because you're not allowed to bring in any, thing.
Oh my gosh.
She would empty the pill bottles and put them like in a big bottle of ibuprofen and get them back in across the customs border. And nobody ever checked it, but, she was always terrified that they were going to, find her bringing in these illegal drugs. So, and everything we did seemed to work briefly for, he'd have maybe a month where he did real well, and we'd be real optimistic and hopeful that this was going to be it. And we kept hoping that if we could get his seizures under control, that he would start having some development. And we just,
because at this point,
we had no idea.
No genome is like, so, you can't even run a genome. None of that's been done.
No.
So do they think it's genetic, or they didn't even know?
With highly suspicious, because he had an MRI of his brain that was normal, and it was all put together right. No structural abnormalities or anything. He looked completely normal. He didn't have any kind of dysmorphic features or anything. There was nothing complicated about the pregnancy. It was an easy pregnancy, easy delivery. There was no evidence he'd had any kind of, lack of oxygen to his brain or acquired injury like cerebral palsy. So he'd had a lot of metabolic testing. He'd had, just chromosome studies, and everything was coming back normal. And we had kind of quit, by a few years into it. We just were, not looking for,
it is what it
anymore.
Is. Yeah.
Just is what it is. So we're continuing, he was always in up through age 3 through the early intervention first steps program. And then he started in the public school system getting therapies, and never, ever got the ability to like sit up on his own or, roll over on his own, really no functional movements. He would be awake and alert, and you could tell like he would respond to voices and stuff, that he had awareness of, his environment a little bit, but he just couldn't respond or interact at all. So we ended up even resorting to surgery. We I guess he was about 3-4 years old, and we had him admitted for continuous EEGs, and we got a hint that most of his seizures were coming from the right hemisphere, they felt like. And we did at first just a parietal lobectomy where they cut out one chunk of brain. 2 or 3 months, he did fantastic, and we were just thrilled, thinking, okay, well, this is it. And started season again. We went in and took that whole side out, did a hemispherectomy. And of all the things we did, that's the only thing that I regret that we did, was put him through those big brain surgeries, because it ended up leaving him a lot more debilitated as far as just spasticity and tightness on the opposite side. And so that became a big issue with like trying to take care of him. And if we ended up knowing what the diagnosis was, then we wouldn't have done it, because we'd known, well, it's not something focal to that area of the brain. It's the whole brain. So we had a baclofen pump put in him at one time. When he was younger, like every winter, he would get sick with pneumonias, and he was in the hospital once or twice. It seems like at least once or twice every year up until he was about 10 with pneumonias. And he was developing a bad scoliosis where he was just real curved, and it felt like it was really compromising his pulmonary function, leading to a lot of the pneumonias. So we did a spinal fusion in 2005. 2005, because it was my last year of med school, is how I remember it. And he's born in 01. No, he was born in 97. So he was 8 years old when we did the spinal fusion, and boom, he did great. Didn't get sick again it wasn't sick enough to be in the hospital probably for 10 years. Wow. Somewhere in there, we also had a VP shunt put in. After his second brain surgery, he developed some hydrocephalus where he wasn't draining his spinal fluid good, so we had to have a VP shunt put in. He'd had the G tube. I'm just trying to think of his surgeries right now. So the G tube, the VP, 2 brain surgeries, a VP shunt, had a baclofen pump put in for a while that we did. And then he had the spinal fusion. And then I think the last surgery we did, his spasticity was just getting so bad, it was hard to take care of him. It's hard to spread his legs to get his diaper on and get him dressed and that sort of thing. So we did a dorsal rhizotomy where they clip nerve roots at the base of the spinal cord to just kind of kill the impulses that cause that spasticity in the legs. And that once we did that, we took the baclofen pump out. So by 2005, we'd kind of done all the stuff, and just he was just kind of comfort care at home, but he did really well. He never stopped seizing, but he never really had like prolonged seizures that were like scary, life-threatening seizures. He would have 2 or 3 just tonic seizures a day where he would just all of a sudden scream out and would get stiff, and head would turn, and he would kind of just make some weird noises, and it would always like terrify people at restaurants. We'd be out to eat, and all of a sudden they'd hear and he'd kind of do the little.
He didn't choke or anything when he did it.
I mean, it looked like if you looked at him, it looked like he was having trouble breathing. He'd like, be making some funny noises, and so it looked real terrifying to people, who aren't used to it. We always would almost laugh because we'd be at restaurants and he'd do one, and people would be looking at us freaking out, and like, how
do I need to call 911?
Yeah, and we're like, it's okay, he's fine. Go ahead with your dinner, it's all okay. So he kind of did that his whole life, and so
go ahead.
Well, and so we eventually, kind of cut his medicines back, saying, none of these medicines are helping. And he stayed on a couple of seizure medicines his whole life, but we cut down a good bit. And he really did. He was pretty stable, I'd say, for about 10 years there, from age 8 to 18, where he wasn't in the hospital ever, except for just some of the procedures that he had, but not because he was sick. And then at Thanksgiving in 18, Thanksgiving of 17. Thanksgiving of 17, he got real sick and was kind of struggling for air. I remember like it was the Friday after Thanksgiving, and we were getting ready. We were up in Jackson, but getting ready to come back down to the coast. And I checked on him like at 3 a.m, and he was like gasping, and really working hard to breathe. And took him up to the ER, and his sats were super low. He got intubated and admitted, and ended up being very tough to get him off the ventilator. It spent about 10 days on the ventilator before they could get him extubated, and then another couple of weeks in the hospital. He had about 3 or 4 weeks in the hospital before we could get the pneumonia cleared up and get him home, just because he just doesn't do anything to cough stuff up. So he kind of survived that, and at that point we kind of decided that we didn't want to do that to him again. It was just kind of an emergency situation. He'd been so stable for 10 years that we really hadn't made decisions about what we wanted to do if that happened. But after that event, we kind of said, well, we don't, we want to take comfort measures, but we don't want to be, aggressive, do everything at every cost if it's not helpful for him. So he got sick in spring of 20, again with pneumonia, same sort of deal, and just working hard to breathe. So we got him in. He and this was actually in March, because it was right at the start of the COVID stuff. And he had pneumonia, and he did not have the COVID, but just a plain old ordinary run of the mill pneumonia. And while he was in the hospital, they started shutting things down and going on lockdown at the hospital, no visitors and that sort of thing. He was in the ICU, and we had by this time, so we had decided, we weren't going to let him intubate him and put him on the ventilator. So they were just having to do high flow oxygen. And they were able to keep him comfortable and keep his sats up, but they never really could wean his oxygen requirements and wean the pressure on the CPAP and the BiPAP things. So it just got to be a nightmare because nobody could come up to the hospital. So Angie was having to stay with them, and
she couldn't leave.
She would leave because he was in the ICU, so he had one-on-one nursing care 24/7. But she would feel guilty when she would leave, and then she couldn't. Her parents, no other relatives, even his sisters, weren't allowed up there. You could have one visitor assigned to a patient, and that's it. And I was up there just because I worked there and on staff, and they would let me in. But I even had a couple of the ICU attendings tell me that I couldn't stay at the bedside with them. Other ones who knew me well would, they wouldn't make a big deal of it, but the newer ones who I didn't know well would, be apologetic, but they would have, it always drove me crazy. Instead of just coming over and telling me themselves, they'd have the nurse tell me, so-and-so says that, you can't stay at the bedside. And I'm like, okay, whatever. So, and Angie just said, I just can't keep going on like this.
This is how long was this?
So after 5 weeks, we said, we just want to take him home. We don't know how he'll do. Whatever support we can do at home. And they said, so we started talking with the complex care. He had never been on the complex care service, which just is for medically fragile kids, where they have pulmonary and neurology and GI and all the different disciplines. And they talked about a different type. And he was wearing this face mask that was just putting so much pressure on him. He was wearing a hole through his nose. Got some pictures. It was just, rubbing him raw because they had to keep it so tight because you can't have any leaks around it. And, he was fighting against that. And then they would try to switch it to a face mask that went all the way around his face. But he just had this terrible wound that had developed across the bridge of his nose. And so we just said, look, we're just not going to keep doing this to him. We want to take him home however we can. So they had come up with this newer thing that's a high flow, but it's just nasal can, but it can actually deliver 25 liters a minute of.
Is that the RAM? The RAM?
Humidified. I think that's what they call it.
Yeah. Okay.
It's got a little bottle on it that has air that's being like humidifying the air, and it seemed to we were trying to get him set up for hospice, and they switched him over to this new machine that we'd be able to come home with, and it actually started doing better. So initially they were saying, well, when he goes home, we don't know if he'll last more than a couple of days, with his oxygen requirement. But when we put this new thing on him, it's like he was so much more comfortable with not having that high CPAP stuff on him, BiPAP, that he really kind of started doing better the last couple of days. But we got everything arranged, went home on hospice, and with the ICU attending doc really saying, it could be days, it could be weeks. I don't think it'll be much more than that. And of course, he just came. Angie and I said that he said, "You dumb sons of bitches! I'll show you give up on me." So he kind of turned it around, and so we brought him home. He got in the hospital in March, brought him home toward the end of April, and had hospice nurses coming in. At first they were coming every day, and then they saw he was doing fine. They came in twice a week, and then once every couple of weeks, and brought him back down to the coast of Biloxi. We'd been up at our house in Flowood, and so we left him on that oxygen setup at night when he was sleeping, but during the day we had him off of it, and during the day he really kind of got back to himself. So he really kind of seemed to be back to his baseline. And December 17th, we had several things set up. He had really outgrown his wheelchair. He was going to get a new wheelchair delivered Tuesday that New Motion had set up for him. Hospice had said, look, we're going to have to release him just because he's stable now. He's not, he's leveled off, and he really don't meet criteria. So they were planning on taking him off on Monday, the 19th. And we were kind of scrambling with the complex care folks trying to get all this equipment changed over to non-hospice, because just with insurance and all this kind of stuff, it had to have a different contract for it, because it was being contracted through hospice rather than to him. So
Oh, yeah.
we were working on getting all this stuff taken over, and so we were 2 days away from that. And the day of the 17th, I mean, he had a normal night. Got him up and was in his chair, and he kind of started wheezing a little bit, and just it wasn't struggling or anything. He didn't look uncomfortable. You could just hear him kind of just kind of a squeaky breath. And so Angie gave him an albuterol nebulizer treatment, and we got him back up in his chair. And she just, she kind of started freaking out, and just was panicky that he wasn't breathing good, and called me. And and I was literally like getting some gym shoes on and about to like leave the house to go to the gym. And like in 5 minutes, I would have been gone. But
because this is a Saturday, it's not a work day, so you're home.
Yeah, so I'm home. So he started getting real pale, and you could just tell he just wasn't breathing deeply, but he wasn't struggling. He wasn't fighting for air or anything. And we got him on the oxygen, but really by the time we did, I mean, he just kind of quit breathing. And so within 3 minutes, of her really realizing that he wasn't breathing well, he was gone. And so, while it was awful, we really, in thinking about it later, said, we couldn't have written for it to go any better, because we were both home. And I know she would have just been awful if it had been her by herself. About 2 weekends before, she had gone on a little 4-day trip, which she never does, with some girlfriends of hers to Nashville, and I was taking care of them myself. I had some nurses some of the time, but most of the time I was by myself with them. And I thought, man, and I remember even thinking while she was gone, I hope nothing happens to him while she's gone, because she'll blame me for not taking as good a care of him.
Yeah.
So, I was just, glad that I wasn't there by him with myself, not because I would have been afraid, but just I didn't want her to have any blame for me. So, and then he did it right before the hospice. So when he did, pass away, we were able to just call the hospice nurse. Took her about 45 minutes to get out there, but she took care of everything. We didn't have to worry about who to call or what to do. She did everything for us. And so we really feel like his death was as easy and as peaceful, and we never saw him suffer. He didn't seem to be struggling or anything, so we were grateful for that. So that was December 17th. And so he lived 23 and a half years, almost exactly. He's born June 17th, December 17th. Or I'm sorry, 19th. I can't. It's odd. Some people just really remember the dates. I hate that. This day, but right at 23 and a half years. And then kind of the backtrack, so getting the diagnosis. We several years ago, having 3 daughters who were old enough to have babies of their own, we always knew it probably was something genetic, and the technology had come so far, and there were so many genes being discovered. Like he'd been diagnosed with something called early infantile epileptic encephalopathy, which is not really a specific diagnosis, just what it says. It is early infantile, very early in infancy, start having seizures, and encephalopathy, you got a bad brain. So it's kind of just like saying developmental delay. Kind of has a characteristic, terrible looking EEG. So there were, only about 4 or 5 genes that had been identified with some of these early infantile epileptic encephalopathies. Now there's like over 100 on these panels. So when the girls were old enough, we said, well, let's revisit it, see if we can figure out anything, because maybe he's got some autosomal recessive thing that they could be carriers for, that they would need to know about. So we got with the genetics department at UMC and did this whole exome sequencing, and boom, it popped right away. He had a mutation in a gene called CDKL5, which stands for cyclin dependent kinase like 5. And the gene was first described and discovered in 2005, I believe it was, when he was about 8 years old. And they described it in mice, and what role it had in function. And it wasn't really until a few years later that they started identifying it as a disease-causing process in humans. And so Manning was already 10 years old by the time the gene was understood what it did in humans. And since then, it's had a lot of information about it, and it's it's on all the early panels now. And kind of one of the first things they check in girls who have developmental delay in seizures, because the gene is on the X chromosome, which means if you're a girl, you have 2 X chromosomes. So you have 2 copies of the gene. And if you have one bad copy of it, you tend to have problems. It's very much like Rett syndrome, RETT, which we typically always in school they teach you is like a disease that only girls have because it being on the X chromosome. So in girls who CDKL5 is actually very closely related to Rett syndrome. It's the gene that lies right next to the gene for Rett's, and it phosphorylates that gene. So it essentially, even though it's a separate gene, it causes the same problems that Rett syndrome would cause. And so girls who have Rett syndrome typically, have developmental regression around 2 or 3 years old, develop loss of language. Often they start talking but then lose it, and it's always kind of been considered an autism-like disorder. They start developing weird hand movements and hand wringing, they call it, and regress, start having seizures, and end up, pretty delayed intellectual disability, autistic features, seizures. But they usually can walk and have motor skills and can interact. Whereas we always kind of taught that boys don't even survive to be born because they only have one X chromosome, so XY. So if you have that gene defect on your single X chromosome, you don't get any activity, and the genes involved in synaptogenesis. So synaptogenesis means like building the synapses between neurons. So neurons talk to each other through connections called synapses, and it's the way that neurons make connections in your brain and networks and pathways. So if you these genes are involved very early in utero as your brain's being built to help to build the connections between neurons so neurons can talk to each other, and you're constantly making new synapses. Like as you learn new things, you're making new synapses and making new connections in your brain. So with this gene defect, you can't make those connections, so your brain just literally never is able to make new connections and learn things. And
it's worse in boys.
And it's worse in boys. And normally they say it's lethal in boys. So like if a boy has this in utero, they're just so messed up they self-abort and don't get born. There's very, very few boys who are described, and most of them pass away very young. I've seen one paper where there's like 19 reports of males with this, and they're pretty much all like Manning, just neurologically, devastated, no development at all, terrible refractory seizures. And so there's just not many boys born like this. So most of the time when people talk about CDKL5, it's kind of a female disease just because there's so few, boy fetuses that live to be born with it. But like I say, now it's on all the early panels, and it would have been picked up right away. But it was a de novo mutation, which means Angie didn't carry it. It just happened spontaneously, at conception with him. So there was no.
Did she get tested? Is how you know that?
And with the whole exome sequencing, which we did, they get samples from both parents because there's so much variation in so many genes that are like that they don't know, hey, is this just a common change that is out there in the population, or not? And they know some genes have a lot of variance in the population, just like hemoglobin gene. That's why some people have sickle cell. I mean, there's a lot of just variance. So because with this whole exome, because there's still so many genes that they really don't completely know the inner workings of. With whole exome, you really want to do both parents so you can compare. Anytime you get a change, there's like a quote standard human genome, but no two genomes are alike. They all have some differences, but they compare the sample to the known kind of human genome, and then any variations, they look at the parents and say, hey, do the parents have that variation? And then they have plenty of data now on the general population. They go, oh, that change is seen, with a 5% frequency in the general population. Okay. And if they get one that they go, well, we don't really know this, we don't see it that much in the population. It's very, very rare. Do the parents have it? And if the parents have it, then they think, well, that's less likely to be causative. Neither parent has this condition. Right. So it probably is a benign variant. However, if they find something that they say, oh, we've never, seen as
unknown significance,
and neither parent has it, it's much more likely to be significant. And then in that case, they start doing like computer stage. Well, what effect would this change in the code for the gene have on the finished protein? And sometimes they can tell, oh, that's absolutely going to be deleterious for the protein. The protein that's created from that gene is going to be truncated too early, and it's not going to be a functional protein. So, there's a lot of analysis. All that stuff with the whole exome sequencing is really fascinating because it's not the science of actually spelling out, like we all have about 2 billion base pairs of nucleotides in our genome. And the technology has been around a long time. Just, okay, let's read it out. Let's just spell out those 2 billion base pairs. All of the real science and expense and expertise in it is interpreting that huge 2 billion long string of things and knowing where the genes are in that. Because most of that DNA, most of those 2 billion pairs are not coding for anything. It's just junk DNA. It doesn't, they're
like
not
80%, isn't it? Like
yeah.
80 or 90%? Yeah.
Yeah. Okay. So that's, we're learning more and more stuff, about, okay, how to interpret it and what it means, and, what parts of that are coding for genes. And then, like with Willow, knowing, okay, that makes this, enzyme that, creates, all these other sulfatase enzymes that you have to have. So, anyway, if he were born today and presented like this, within a couple of months after birth, we would know what he had. But at the time, we
wouldn't have changed, and it wouldn't have changed anything.
There was nothing different we could do. And
there's no treatment. There's no thing to do. Right.
And because I've thought a lot about with Willow and the genetic treatment, like, well, how could the treatments that they're developing for her help with something like this? And theoretically, I mean, it's still a long way from doing it, but you've already got a proof of concept that you can alter genomes. And if you could discover this, like in utero as the brain's being built, like, why couldn't you inject that gene into like the amniotic fluid and make that protein available to help build brains? And
right.
I don't feel like it would technically be something that could never be done. It would be a completely different way, because you really got to introduce it. Whereas Willow's condition is a problem with this buildup of storage material, and the earlier you can provide this enzyme so that you can start breaking it down, the less damage that's already been done. With Manning's condition, it was more a problem with, like, you can't build these connections, but the earlier on, even in utero, that you can provide it, your brain could start making connections. And even if you did it like after birth early on, theoretically, if you could get this protein going, your brain would be able to start building the connections between neurons. And the fact that girls who have this can seem pretty normal up till they're about 2 or 3 and have regression, also tells me, okay, there's some, if you have some functional
right, you just need to increase it a little bit, or not. Yeah. So are they?
But there's not a drop dead date, like, oh, if you don't have this by birth, then
right,
you're not going to be safe. So anyway, I feel optimistic that with the things that are happening with the United MSD thing, that a lot of the things we learn from curing MSD are going to be transferable to other conditions like we've talked about. Okay, and not just storage, because a lot of things we've been talking about are the storage things where you're building up these things in cells. But there's a lot of other conditions that that
it's basically just fixing the functioning that's broken. So you just put the gene in that this gene is wrong, and you just fix the functioning that's broken. Right. So, okay, cool. There's 2 other things I want to talk to you about. So do you want to get in the car, or do you need to get in the car?
I'll start packing my stuff up. Go ahead.
Okay. So the first one is back to, so when Manning was how old, and how did you decide to go to medical school? Like, tell me that. Process.
Okay. So, well, like I said, I was kind of, while I liked my job, I didn't like all of the, people telling me what to do, and, having to wear the suit and tie. So he was born in 97. I'd been there. I graduated from college in 89. So, I'd been at Southern Farm for 8 years. And by 1999, just meeting with the doctors and everything, and just kind of becoming interested in medicine and reading a lot about it, I just thought, well, heck, I could do that, so I started looking into going to med school. And then kind of an inspiration, like where we're going to a church, there was a fellow, and I can't remember what he did before, but he was in his 30s and had decided to go to med school. And I don't even remember what it was he did for, maybe like farming or something. I mean, something kind of real blue collar. And, I remember just looking at him going, well, dang, I could do that. Like, why couldn't I do that? And this is kind of corny. I don't know if we want to put this in anything, because I'm almost like embarrassed about it. But there was a movie called October Sky that came out in theaters around then. And it was about this young kid who wanted to like be a rocket scientist or something.
I remember that. Yeah.
And it was kind of about like, well, you can do whatever you want to do.
Yeah.
And I remember coming out of that movie going, it was kind of like this inspirational, like, find your true love and go after it. And I kind of came out saying, well, and I just like made up my mind, well, I'm going to go to med school. And, you know, a lot of people told me I was a crazy guy. I really had a very good job making, you know, a lot of money for a Mississippi, you know, 20, you know, let's say I was in 6'7", so I was 30 when Manning was born. So by this time I was 32. So, you know, I was doing real well for a 30-year-old. I mean, well, Angie was staying at home and taking care of the kids and all. And so people are like, are you crazy? You're going to quit this job? Like, you've got you could spend your whole career there, you know, retire. And, you know, do you really want to do that? And I thought, well, yeah, if I'm not doing something that, like, I'd look around at all the people who were there their whole life. And it's the kind of company where, like, it's this old white boy kind of, you know, old South, you know.
Yeah. Every day they come in with their tie on, and
kind of your good old boy, white guy, no, you know, everybody, you know, old South people. And
and you are working for an insurance company, so it's not like you're changing lives. Yeah.
And you know, and it was like all the guys I looked at who were 60, 65 years old, who had been there for 40 years. I thought, damn, I don't want to be, you know, one of those guys. Like, and so I just was thinking, you know, I wasn't really happy with what I was doing. And then the thing that I am involved with all the time, I found just real interesting and fascinating. And all these, you know, doctors that I were talking to, just, you know, just it seemed like they enjoyed what they did. And I just like came up to a decision, yeah, I'm going to go to med school. So I went to the dean of admissions and told him, look, this is what I want to do. What do I need to do to get? I had no idea. I had not done any kind of pre-med course. I had no idea what the prerequisites were. So they looked at my transcripts for MilStaps and they said, well, you don't have any organic chemistry. You don't have any biology. You got to have this. I did all the hard sciences like math and physics and chemistry. So, you know, they say you need some life sciences. So essentially all I lacked from my college transcript was 2 semesters of organic chemistry in labs and 2 semesters of biology, zoology in labs. And she said, look, you know, you're
what about like anatomy and physiology? Like, doctors don't have to do that?
Never. Yeah, not necessarily as pre-med. There's only so much that, I mean, you definitely have to have it in med school, but so she said, look, you know, with all your coursework from MilStaps, that stands by itself. You don't have to go spend a lot of money. She goes, just go to junior college and get these, you know, because it's just, you just have to check the box that you have them. So I took night classes at Hines Community College and did, you know, a year worth of each of them, 2 semesters of both of them. And so I applied to med school while I was finishing up. I didn't get in the first year. And so I was real disappointed that I hadn't got it. I took the MCAT test and you know, it's not uncommon not to get in your first year. I know they were taking about 100 people a year, and they tell me they have about 300 applicants. So, but they would encourage me to apply again. And like some of the insider people were telling me, look, you know, especially with older people like you, they want to be sure this is not just a whim. By this time, you know, I was 33, and they're saying, you know, they want to be sure it's not just a whim. You're just tired of your career, and that you're really committed to it, because they don't want you to come in and then after a year go, nah, it's not really for me, and move on to something else, because, you know, these spots are coveted and they don't want to take up a spot, you know, with somebody who's not really serious about doing it. And they said, really, you know, they really like to see you stick to it and have some like other kind of medical experience, like, you know, shadow some people. So I did, you know, over the next year, some, you know, just shadowing around people, and got in the next year. And so
and this is at UMC?
This is at UMC. Okay. So I got accepted on my second go round, and
so then you go quit your job? Did you quit your job then?
Oh yeah, I had to quit my job. So I quit my job in about June, and med school started in August. And you really can't work. I mean, like, school is like, you know, 8 to 4 classes and labs and stuff, and then you're just studying so much. And I remember the people told me that it's like the amount of information you're getting is like trying to take, you know, a sip of water through a fire hose. Yeah. Just because it's just so much. And I really kind of agree with that. I mean, none of it was like technically hard. Like, you know, I was a, you know, math major, and, you know, like did advanced calculus and stuff, and like the stuff that was conceptually difficult, like that I really had to like sit and think about, you know, what it means and stuff. And nothing in med school is like a high school kid can learn it all. It's just so much volume. It's just, you know, like every day just throwing so much information at you, and if you don't keep up, like, you just drown.
Yeah.
And so and I had no background and stuff, and I remember just thinking how random everything seemed. And so you're doing anatomy and physiology and biochemistry and histology and, microbiology. And to me, like, I didn't really have a good organization structure in my mind. I kind of likened it to just like having an empty room and all this information was just getting thrown in on the floor. And I just had a junk room with all this stuff.
Yeah.
And then after a couple of years, I really learned like how it all kind of fit together and organized. And I said, man, if I could go back and start over right now, I feel like I would have the shelves in place of how I wanted to organize all this stuff in my mind, and that I could organize it a lot better and really understand it a lot better. And I didn't have the best grades in med school, but I also didn't stress. I mean, I had 3 kids. Mackenzie, my last daughter, was born in May, the year I started. So I had 4 kids at home, and I didn't really stress too much about grades. There's a lot of people in med school who are just like super, we call them gunners, who are, they're cutthroat. They're so afraid about like matching into the residency they want, that if they get any kind of edge, they don't share any information with anybody. It's very almost cutthroat and competitive, and I just wasn't like that. Here I am in my 30s and I got kids. I sure didn't have time to worry about like a 23-year-old kid who's never had a job, if they get 2 points per test. And it always amused me. One of the things that I thought was so funny is after every test, the whining and bitching and moaning about like, and that is not a good question. And, and they would like, they were always going to the professors and whining because they made a 96, but their neighbor made 100. And they're so afraid that person's going to be ahead of them. And so they would want to go and argue the question and all this kind of stuff. And it got to be so bad that the professors would say, y'all can't come arguing. And so they made the class president select a committee, and that they would go to questions, and one person, so like the class president, could go and discuss, questions
all the
on the exam to challenge them to all the issues, because so many people complaining that they didn't want to hear from everybody. And so I was just never in that crowd. And I kind of finished like in the middle of the class, and I kind of followed that old joke about like, what do you call the first person in the class, valedictorian, and what do you call the last person in the class, doctor.
So okay, good. All right. So let's talk about Willow. So you remember back, you were still at Singing River when she was referred to you because of developmental delay.
Right. I remember her well coming in.
Yeah. So kind of, tell your version of that story, like the way you saw it.
Well, as I recall, you and Tom both came in with her that first time. And we're just concerned because she really was not meeting milestones. And was she 2?
Yeah, she was 2. So we saw you, her birthday was in August, she turned 2, and we saw you, I believe, in like January or early 16.
Right. And so, that's one of the more common referrals we get is for developmental delay. And one of the big things that's kind of a red flag for me is if there's seemingly been some regression. We see a lot of kids are delayed, but they're continuing to go forward, and they may be behind other kids, but they're not losing ground. And you were just starting to mention there were some things that she seemed like she had been doing, but wasn't doing as well anymore. And that's always a concerning thing for us.
I remember she couldn't, like, she was trying to get up on your table, like up on the table, and she was getting up the steps, and like she was a little off balance, and like that seemed unusual to me. Like it wasn't, she'd always kind of walk like Frankenstein because she was scared of her balance, but she would have been able to go up those stairs a few months earlier without such issue, or that step.
Right. Yeah. And so that always, raise a red flag. But, one of the standard things we do with kids who have a developmental delay and we don't recognize something, like there's nothing about their birth history, which is sort of similar to mine, to suggest that she had a brain injury. Like, you didn't have a difficult delivery where she got cut off from oxygen. They had to revive her. She didn't have a bleed in her head. She didn't have trauma. There was no history of, like some bad infection during your pregnancy. So then, looking at her, she did seem like she had a little bit of what we would call like coarse features, what the genetics would call coarse features. She kind of had the dry skin, which didn't really ring a bell, but it just kind of little odd features, and just, for lack of a better term, coarse features that is a term that geneticists use a lot. So just looked a little bit different. And, that always kind of makes us concerned about some sort of genetic chromosomal disorder. And the standard thing looking at now is a microarray analysis, which is a high resolution look at all of our chromosomes, looking for little bits of deleted or duplicated material. And it's not nearly as thorough as a whole exome sequencing, but it's akin. I always tell people, like, looking at 46 chapters of a book with each chapter representing a chromosome to see, hey, has a page been torn out of this chapter? Is somebody stuck an extra page in there? Is there a paragraph that's missing? And with Willow, she had a deletion that, as I read the report, spanned a gene called SUMF1, which it was one of the genes in the interval that had been deleted. And so I had to, doing research on that, saw that it had been, that's the gene that is associated with a disease called multiple sulfatase deficiency. And it's one of those things like, oh yeah, I remember hearing about that or seeing that term on board exams, never seen a patient, really couldn't even tell you what they look like, what happens, that have to go back and review it. But it's an autosomal recessive condition, which means if you have one normal copy of that gene and one bad copy, you're a carrier for this condition, but you're not going to manifest any symptoms, or at least anything significant. You're going to be pretty normal. But as I read about multiple sulfatase deficiency, I was like, oh, I don't like that. That kind of fits what's going on with her. And I know she's missing one copy of that gene. So I need to know what's going on with the other copy. If that other copy is something wrong with it, that would give her this disease, and kind of fits with what we're seeing. And around that time, I talked to Mauricio de Castro. I had never met him in person yet. And I think, if I recall right, y'all already had an appointment scheduled with him, maybe.
Yeah, I think so. Yeah.
And so I think I called him and said, look, I know you're supposed to see this little girl. I've got this microarray. She's got this deletion. We're concerned about that. I'm going to go ahead and get analyze the other gene. He said, oh, absolutely. That's what we need to do. and that was somewhere in the time frame. I'd have to go back and look exactly, but he and I had talked before we really got it. And then when I got the results back showing that she did have a point mutation in the other copy of the gene that would render that gene defective in creating an effective protein, I called him and he's like, oh, yeah, that's what this looks like. So I remember calling you and kind of, giving you, and we had already talked when I found the first one, and I kind of explained, hey, there's a potential for this disease. We need to look at the other gene. And so I'm sure you'd had a chance to kind of
I Googled
at it and realized, what this was. So when I had to call you and tell you, hey, this other, this is what she's got, her other gene has a defect in it, that it just hit you hard because you already knew what,
right. Just kind of shocked. I mean, it's just a shocking, it's, you just can't believe it. It's hard. It's hard to explain that moment.
Well, it's hard,
you kind of think rationally, like, like what I Googled and what I saw, it would explain everything. But then you're just like, oh, that's the worst of the worst. Yeah.
Well, and you hear this, like, you never like, how could my daughter have something I've never heard of in my life?
Right.
Yeah.
Well, then you kind of get into the world of like, oh, there's 8,000 other things that you've never heard of. But yeah, when you're and you don't, like, I never had any experience with a regressive disorder in a child. So I didn't know anybody that had one of those. And
that's exactly like we were with man. I mean, we had no clue.
Right.
None. I had no idea that there were babies who had seizures.
Yeah. Right. Yeah. It's not something, so then your world kind of collapses because it's not something you can identify. I mean, like, we can identify with pediatric cancer because we kind of know about St. Jude and all that kind of stuff. Right. But these regressive conditions, like my child has like almost like Alzheimer's, like, and she's just going to decline from here. Yeah. Right. Yeah. And then mind-blowing. Yeah. And then from there, we went to see Dr. Kermsey, which he had saw, I think we saw Mauricio, and then we went to see Brian, and he had seen an MSD patient that had died. I think it was late or neonatal when he was at Washington Children's.
Yeah. And it was really an odd coincidence because Mauricio had trained under him
at
DC. Yeah.
And the fact that he was here in Mississippi was odd too. He had just moved here, I think, the year before. So he was a metabolic geneticist, so right in that same field.
Right.
Yeah. So when we went and talked to him, and he's like, and I think we had asked you and asked Mauricio, okay, like, what do we do now? Like, what do we do? And and then we go.
And we unfortunately, and I stupidly say, there's nothing you can do. You can just take as good a care of as you can. And you say, well, I'll show you. I'm gonna damn cure this thing.
Well, and I don't think you do that. It's kind of like we go up the route of doctors that's in that specialty. So it's like Brian was the one that said, you know, because we're pretty hopeful at that point. You know, we're like going up there, and we're like, he's gonna, you know, he's from Children's National, and like we're gonna go somewhere and do something, you know, and then he's like, yeah, so this is what's gonna happen, and there's nothing you can do. So,
yeah. Well, and then you know, from the time I gave you the news on the phone, I didn't see y'all again for several months, and by the time I had seen you again, y'all had been to Europe talking to people, and I was like, wow, like, you know, there's some parents who, you know, don't get it. You got it and ran with it.
I mean, well, it's just such a terrible diagnosis. So so and then we talked to that dad in Ireland, and it's like it started spiraling out of control there. So then it was just like, okay, now we're on this path, and we start, you know, fundraising and start doing it. So and you had mentioned, you know, and I know you got to go, but just to kind of
I'm actually good. I'm good.
Okay. I want to get like some sound bites of you talking about why it's important to support this research, and, you know, why it's important, like of all the things out there, why you help with this, and why you think other people should.
All right. So, you know, everybody, you know, most people would do anything for their kids. And, you know, I felt like I needed to understand what was wrong with them, because nobody could tell me what was wrong with them. And I felt like my best chance to know what was wrong with them, and, you know, before I could help to fix them or do something, I mean, we didn't have a diagnosis. So I just needed to learn as much as I could. I saw that the best way, you know, well, let me get a med school education. And you know, it wasn't entirely that. While I was interested in it, I was also, I don't really want to be an actuary when I'm 65 and doing this. I want to find something else. And this is interesting too. So I won't say it was entirely like, oh, I hate the idea of going to med school and I hate being a doctor. I just, you know, but I'm going to do it for this. So it wasn't entirely selfless. I mean, there, you know, obviously it's had benefits for me too, but essentially I went because I needed to find out what was wrong with my son. You, on the other hand, like had a diagnosis, you like, okay, well, I know what this is. And I've learned, people are telling me there's nothing I can do. Well, by God, I'm going to find something to do. And, you know, you've applied all your efforts into this. I mean, it's amazing. Just, you know, a local person here, you know, in Ocean Springs, Mississippi, has created this, you know, the worldwide organization for, you know, finding a cure for this. And, you know, so it's been inspirational to see how much you've done. And because of our history, you know, my history, I've become very, very interested in genetics. You know, I find it very, you know, intellectually challenging and interesting, and just, I mean, just so fascinating. So I just, you know, it's just instilled a great, you know, curiosity in me. And then finding all the new things that we can do about it, you know, with CRISPR and that sort of thing, the gene replacement therapies, I mean, just how incredible is it that you get a virus that could be a harmful thing and use it as a vector to insert, you know, a helpful piece of, I mean, it's just like something out of a science fiction movie. So, you know, realizing what all you've done has made me think, well, what could I have done, you know, if I had known what was going on with Manning? And certainly with the kind of conditions our children have, the only thing you can do is fix those genes. And, you know, while it used to be just like a pipe dream, I mean, like it's a reality now, like it's possible, like it's been proven that, you know, it's possible to do so.
Like it's not, you know, not that other things aren't doable, but like, you know, heart disease and cancer and all that, it's like kind of far away. And it's like, I can't see what's happening with the money. I don't even really know what they're invested in. I don't know what they're thinking as a treatment. Like you literally know we're doing AAV9 into the body to do a gene therapy with the SUMF1 gene. Like
that's a big thing. So, you know, the MSD Foundation has a clear goal. This is what we're trying to accomplish. It's not nebulous, it's concrete. That's very important. It's very, while it seems isolated, and, you know, you can anticipate the criticism. Well, how many kids have MSD? There's not that many. What are we going to do all this to help, you know, the 3,000 kids, you know, that have this, or whatever the number is? We know that most cases are not diagnosed, identified, but you know, the answer to that is, well, the things that you're doing in Ray's research could help all of those storage diseases. It could help my son's, you know, type of condition. I mean, I really believe, you know, the whole zebra idea that you know, does rare disease are rare is certainly true. I suspect I'll never diagnose another MSD. I may meet some people just through your contacts, like we met the lady from Louisiana the other day. But the odds are infinitesimal that I'll ever diagnose another one. The odds are very small that I'll diagnose most of these rare diseases. But every month I diagnose some rare disease, a genetic disease. Like I'm keeping a spreadsheet list. I've got, well over 200 kids with genetic conditions. In total, they're not that rare. It's just that each individual is rare. We already said the human genome, has about 2 billion base pairs. There's about 20,000 genes in the human genome. That's a lot of genes where there's room for something to go bad. So, the things that the United MSD Foundation is doing to find cures is proof of concept for treating and even curing a multitude of other genetic conditions. And genetic conditions tend to have neurologic, consequence.
Right.
So.
Yeah, most of it's the brain.
In the short term, yes, it's very appealing that you're not just dumping money that you don't know where it goes, that it's very concrete. You know what's going to happen with the money. But, to fight against the thing, well, yeah, we're going to cure this one rare disease, and I'm never going to know anybody who has this. No, by helping to cure this one disease, you're going to provide information and knowledge and science that's proof of concept and is transferable to a multitude of other diseases. And you can help, your grandfather avoid Parkinson's disease, and your uncle, with Alzheimer's disease. It's definitely going to be transferable. And that's the way all of science in general, and medicine in particular, advances, is just little baby steps at a time. And you have to attack one problem before you can generalize that to other problems. And that's a good way to put it, I think. We're attacking one small specific problem, but it is going to generalize to a lot of other conditions. Right. And, having, a child like Manna for 23 years, if anything can come out of that we could help somebody else in the future, it gives his life some meaning.
Yeah. It was super special. Okay. All right. I think that's it. If you want to real quick tell the zebra thing in like 1 minute, like why is it called the zebra run? What's the zebra?
Zebra in medicine is a rare disease. In medical school, a common, meme or mantra, if you will, is when you hear hooves, think horses. Common things are common. So when you've got somebody in the clinic, a child with a cough, think about common cold. Don't think about tuberculosis. That doesn't mean those rare things don't happen. So when you hear hooves, think horses, but don't forget the zebras is always the caveat. So when you've kind of ruled out common things, okay, now let's expand that. Could this really be a zebra? So we don't see too many zebras, in the United States, except in zoos. So, we just need to remember that sometimes those hooves are not a horse, it is a zebra. And so zebra has become kind of the symbol for rare diseases, in particular genetic rare diseases. So the Zebra Run is all about raising money for research into rare diseases. It's sponsored by the United MSD Foundation. So specifically, we're trying to raise money to cure this terrible disease, which is one of those zebras. But you can help for a number of diseases by contributing to this cause for the reasons we mentioned below. I don't know if you want to spice some of that together, but but by contributing and becoming a sponsor for the Zebra Run, giving your time, your money, encouraging other people to give. This isn't going to happen from, one or two people alone. It's you raising awareness with all of your, family and friends. We need sponsors. We need runners. We need help raising this money. And by doing so, not only are you going to be helping children with this particular zebra, but you have the potential to help with all of these zebras. And while each zebra is rare, you put them all together and there's large herds of these diseases out there that need treatment and help. So reach deep. Awesome. And let's get behind this run.